Good morning, everybody. It's a real pleasure to be here to talk to you about acute kidney injury syndromes. So first, my disclosures, none relevant to the talk today. This will be a case-based series of presentations that go over cases that will probably show up on the boards and that you are, of course, familiar with clinically. So the first case, 65-year-old man with known alcohol dependence was found unconscious on his living room floor. He was brought to the emergency department where he was intubated for airway protection. His vital signs following intubation showed a temperature of 98.3, blood pressure 86/54, heart rate 116, O2 saturation 99% on FiO2 of 0.4. His labs are here. He has hyperkalemia, metabolic acidosis, and acute kidney injury. His phosphorus is 8.5, uric acid is 4.3. So his urine was noted to be red. After centrifuging the urine sample, it remained red. A centrifuged plasma sample was yellow. So what is the most likely cause of his acute kidney injury? We don't have an audience response here, but A, hemolysis, B, rhabdomyolysis, C, acute intermittent porphyria, or D, paroxysmal nocturnal hemoglobinuria. Anyone for A? B? Great. C? Even better. Okay, and D, no votes for D either. So this is rhabdomyolysis, and you knew that from the clinical presentation. But just a quick word about the color of the plasma and the urine. This could come up on a board exam question. The urine is supernatant is clear, of course, in hematuria, but remains red in rhabdomyolysis as well as in hemoglobinuria. The plasma supernatant may remain red in hemoglobinuria because of hemoglobin's large size compared to myoglobin. So in myoglobin, in rhabdomyolysis, the plasma supernatant is yellow because myoglobin is filtered and cleared by the kidneys. So rhabdomyolysis, let's talk about this, this condition which you all are undoubtedly familiar with. Rhabdomyolysis refers to the breakdown of skeletal muscle, which leads to leakage of intracellular contents into the circulation. So creatine kinase is the marker that we use. Other enzymes that are released into the circulation are aldolase, LDH, ALT, and AST. There's a variable rate of AKI in rhabdomyolysis depending on the clinical context. In some conditions, in some contexts, about 50% of cases with significant rhabdomyolysis develop AKI. The causes are numerous. So there's first crush syndromes and limb compression. You can also get hyper-CKemia, as it's called, or elevated CK levels after strenuous exercise or after seizures. Now, those two conditions are not as frequently associated with AKI from rhabdomyolysis. Other causes of rhabdomyolysis are disorders of glycolysis, glycogenolysis, abnormal lipid metabolism, certain infections, influenza A and B, Coxsackie, HIV, EBV, strep, and staph infections can cause rhabdo, heat stroke, malignant hyperthermia, malignant neuroleptic syndrome, and then certain electrolyte disturbances, severe hypokalemia, hypophosphatemia, hypocalcemia, and in cases of diabetic ketoacidosis, you can see an elevation in the CPK. And then the drug causes of rhabdomyolysis that you're undoubtedly familiar with: fibrates, statins, alcohol, heroin, and cocaine. So the pathogenesis of rhabdomyolysis, why do patients develop acute kidney injury? It's because of the myoglobin and its associated toxicity. Myoglobin is a 17.8 kilodalton protein that's freely filtered by the glomerulus. It appears in the urine when the renal threshold for reabsorption by the tubules is exceeded. And that's usually when the serum levels of myoglobin exceed about 100 milligrams per deciliter. The pathophysiologic features of AKI from rhabdomyolysis are several. First, there's intense intrarenal vasoconstriction. There's also direct tubular toxicity from reactive oxygen species and free radicals that are produced due to myoglobin. There's also tubular obstruction. So myoglobin can precipitate in tubules with TAM-Horsfall protein, especially when the urine is acidic. And that leads to the recommendation about alkalinization of urine for prevention of AKI. So before we get to that, how do we diagnose rhabdomyolysis? Well, it's based on the CPK level. There's a generally weak correlation between the magnitude of the elevation in CPK or CK and the risk of AKI, but it's relatively rare to develop significant AKI when the CK level is below 15,000, unless you also have another condition like severe volume depletion, sepsis. You'll know that the heme-positive urine dipstick in the absence of red cells is a feature of rhabdomyolysis. So myoglobin is the true pathogenic factor, but it's not used in the diagnosis. So although we sometimes obtain urine myoglobin levels and maybe even plasma, we mostly rely on the CK level. And that's because myoglobin itself has sort of variable kinetics in the plasma. It peaks very early after muscle injury, but its metabolism is quite rapid and variable. So it has relatively low sensitivity for the diagnosis of rhabdomyolysis. One feature of rhabdo that you should remember is that a low fractional excretion of sodium is common. So even though we talked about tubular injury as one of the features of rhabdomyolysis and obstruction and pretty significant ATN, if you look at the urine, for example, there's often muddy brown casts. Despite that, the fractional excretion of sodium is oftentimes low, and that may reflect the primacy of intrarenal vasoconstriction in many cases of rhabdomyolysis. So don't be fooled by the low FeNA. That doesn't rule out the possibility of severe ATN from rhabdomyolysis-induced AKI. So the treatment of rhabdomyolysis is early and aggressive volume repletion, particularly to prevent AKI. The formulation of fluids is often debated on rounds. And unfortunately, there's a general lack of high-quality evidence comparing different fluid types. There are some arguments in favor of sodium bicarbonate-containing fluids because of the alkalinization of the urine, which will minimize precipitation of the myoglobin and TAM-Horsfall protein. Bicarbonate may also inhibit redox cycling of myoglobin and reduce lipid peroxidation, where there's actually tubular injury from lipid peroxidation. Sodium bicarbonate may also reduce vasoconstriction. For all these reasons, sodium bicarbonate, so D5W with 3 amps of bicarbonate, for example, are sometimes suggested as an initial fluid. The one risk, of course, of bicarbonate-containing fluid is the risk of inducing hypocalcemia, which can be a significant issue in rhabdomyolysis. So normal saline is, of course, used, is probably the most commonly used solution in intensive care units. And the disadvantage, of course, with significant volume repletion with saline is the development of hyperchloremic metabolic acidosis. So I'll show you some recommendations on which fluids to use from a recent review article, but there's still some controversy over bicarbonate versus hyperchloremic solutions like normal saline. How about diuretics? Diuretics clearly have a role in the management of rhabdomyolysis, but they should only be used after volume repletion. Mannitol is one in particular that has not been well studied, but at least I have found to be quite effective. Mannitol is a potent diuretic. It's an osmotic diuretic. It can help clear the tubular lumen. There may also be antioxidant properties of mannitol. And it also may improve lymphedema in cases of like Crush syndrome. Loop diuretics are frequently used, probably the number one class of agents used for oliguric AKI, not well studied. But both loop diuretics and mannitol can be used for converting oliguric AKI to non-oliguric AKI. So the treatment guidelines, I think The review article that I really turn to and show the residents who are on service is from Bosch and colleagues in the New England Journal of Medicine in 2009. And these are their guidelines, their suggestions. They suggest to prevent AKI, normal saline at 400 mils per hour. They suggest checking the urine pH, and if it's below 6.5, to alternate the saline infusion with D5W 1/2 normal saline plus 100 milliequivalents of bicarbonate. Their target urine output is 200 mils per hour with frequent checks of potassium to prevent or to avoid hyperkalemia and be able to treat it with dialysis, of course. They also recommend correcting the hypocalcemia that occurs as calcium gets sequestered only if it's significant, and particularly, of course, if it's associated with tetany or seizures, or if there's concomitant hyperkalemia. Their suggestion is for mannitol up to 200 grams in a day and less than 800 grams total, and to discontinue it if there's no diuresis established. They also suggest checking a plasma osmolarity and gap, and stopping mannitol infusion if it's greater than 55, the gap. The hyperkalemia management as usual, loop diuretics for converting oliguria to non-oliguria, and of course the usual indications for hemodialysis such as hyperkalemia, anuria with volume overload. So this is a good review article that goes over not only the pathogenesis, but also has a really common sense treatment guideline. So we were interested in rhabdomyolysis from an epidemiological perspective, and in particular trying to predict who is at highest risk of developing AKI. So Garode McMahon in our division published this paper in JAMA Internal Medicine. We looked at about 2,000 patients from the Brigham and Women's Hospital and Mass General, and we divided the two hospitals into a derivation cohort and a validation cohort. And we included anyone who had a CK level of greater than 5,000 within 3 days of admission. And in one of the hospitals, we derived a prediction score, and in the second hospital, we validated that prediction score. So the variables that came into the model, and this was to predict who with elevated CPK on admission goes on to develop either severe AKI requiring dialysis or actually dies in the hospital. The variables that were in the model are age, gender, the initial creatinine, the initial calcium level, the initial CPK greater than or less than 40,000, the etiology of the rhabdomyolysis, the phosphate level, and the bicarbonate. With those variables, you can get actually very reasonable prediction of a sense of the probability of dialysis requirement or mortality with an AUC, which is a metric for evaluating the performance of a prediction score, AUC of 0.83, which is quite reasonable and better than like the Framingham risk score, for example, for a different condition. So this calculator is available online if you Google Brigham and Women's and Rhabdo, and could hopefully be helpful. So that's rhabdomyolysis. Let's turn now to our case number 2. This is a 48-year-old previously healthy man who presented to the emergency department complaining of fatigue, anorexia, and weight loss. He was on no medications, and on exam, he was hypertensive with a heart rate of 98, respirations of 16, and O2 saturation of 95%. You can see his markedly abnormal Chem7 here with hyponatremia, hyperkalemia, BUN of 271, serum bicarbonate of 7. He had a normal CPK, calcium of 7.1, phosphorus of 5.3, and a uric acid of 4.3. This is his ultrasound. So when you see a BUN this high nowadays, it's oftentimes obstruction. So this gentleman had severe bilateral hydronephrosis from a urethral stricture. So he was admitted. He's actually continues to be my patient today. He underwent hemodialysis, received bilateral nephrostomy tubes and a suprapubic catheter. We actually discovered the urethral stricture when we tried to place a Foley. His urine output was quite brisk after relieving the obstruction, and he only required a single day of dialysis. So he was admitted to the hospital, and 2 weeks after his presentation, his urine output was 6 liters per day, suggestive of a severe post-obstructive polyuria. He actually ended up being discharged home with a PICC line to be able to keep up with his obligate fluid outtake, and required IV fluids, potassium, and sodium bicarbonate for 8 weeks. So the question I posed to you for this case, metabolic complications during the post-obstructive phase of this polyuria include impairments in A, urinary concentrating ability, B, urinary diluting ability, C, sodium reabsorption, D, urinary acidification, or E, all of the above. So for time's sake, I'm going to tell you the answer here. You probably know it. All of these complications can occur in the course of the polyuric phase of post-obstructive AKI. So post-renal AKI, you all know, refers to the blockage of urine, and it can happen proximally or it can happen distally. It can happen from stones or blood clots that block the ureter or retroperitoneal fibrosis. It can happen, of course, with BPH, or in my patient with a urethral stricture. So a little bit about the physiology of obstruction, and this may be a board question. The early phase of obstructive uropathy is characterized by elevated intratubular pressure, which increases the pressure in Bowman's space. That reduces the single nephron GFR. There's compensatory hyperemia through afferent vasodilation that serves to increase the GFR. Later phase, there's actually vasoconstriction. So initially there's vasodilation, later there's vasoconstriction and reduced renal perfusion, and actually a reduction in the ultrafiltration coefficient across the glomerulus. In recovery after obstruction, it's dependent on the duration of the obstruction. If there's severe, complete obstruction for more than a week, you can have permanent CKD and, of course, ESRD. This gentleman came in with a BUN of 270, probably several weeks of obstruction, so he presented late and developed advanced CKD that did not recover to baseline. He never had a normal serum creatinine, and he actually did develop dialysis dependence about 2 years after the initial presentation. And so his case was marked by tubular dysfunction during recovery, which was very severe and was a management nightmare trying to maintain his fluids through a PICC line. And he also demonstrated that many cases of AKI, particularly obstruction, can lead to progressive interstitial fibrosis even after the recovery, even after the obstruction is relieved. So that's a case of obstructive uropathy. So next case we'll go to is case number 3. This 65-year-old man was admitted for atrial fibrillation with rapid ventricular response. His hospital course was prolonged and was complicated by catheter-associated urosepsis. So he had an indwelling Foley and developed urosepsis. For that, he received ampicillin sulbactam. 7 days into the course of this antibiotic treatment, he developed a diffuse erythematous rash across his chest, arms, and legs. His creatinine rose from 0.9 to 1.7 a week later. And then over the next 5 days, his creatinine continued to rise, and he had a BUN of 96 and a creatinine of 6.8. His medical history was notable for AFib, which was the admission diagnosis, hypertension, type 2 diabetes on oral hypoglycemics, a normal baseline kidney function. His medications were aspirin, metoprolol, lisinopril, which was discontinued when he was admitted, amsulbactam, glipizide, and he also had the need for some intermittent dopamine infusions while he was in the ICU for borderline blood pressures. He had no known drug allergies. His exam was notable for fever, blood pressure of 88/50, tachycardia, and slight hypoxemia to 93% on 2 liters. He had a diffuse erythematous rash on his chest, his arms, and his back. He had crackles bilaterally on pulmonary auscultation. He was tachycardic. He had no friction rub. His JVP was approximately 12, and he had 2+ edema. He had a leukocytosis with 12% eosinophils, BUN of 96, and a creatinine of 6.8. So we got a bunch of tests on this individual. You heard Dr. Bonventry talk about biomarkers, and that's an area of my research interest as well. So we got the following biomarkers to help us manage this patient. We obtained a fractional excretion of sodium, and it was actually less than 1%. You can see his urinalysis or his urine sediment here. He had no hydronephrosis on his renal ultrasound, and he had eosinophiliuria to 10%. So this is a classic case of allergic interstitial nephritis, right? So he had fever, he had a rash, he had eosinophiliuria, he had a compatible drug exposure, which was ampicillin, and compatible time course, developed a week or so after exposure to the drug. So he was actually given a very aggressive treatment with steroids. He got 1 gram of methylprednisolone and then was started on prednisone 60 milligrams a day. He had no improvement in his kidney function after this. We actually performed a kidney biopsy to try to help guide our management. And to our surprise, his kidney biopsy, this is not the actual biopsy, but it was just severe ATN without a trace with no evidence of allergic interstitial nephritis. So this was a case of ATN from his urosepsis and hypotension, also associated with a rash from the drug. So this case is stuck with me, and it guides my management of patients with suspected AIN, and has actually lowered my threshold for kidney biopsy. So this case, it was a late recognition of AKI, and I didn't tell you those details. The biomarker evaluation was quite reasonable. He had, the triad of eosinophilia, fever, rash. But the key was that he didn't respond to steroids. So I think we did the right thing, which is to get a kidney biopsy to actually clarify the diagnosis. So acute interstitial nephritis was first described by Councilman here in Boston in 1898, and this is a picture of the Journal of Experimental Medicine where he described acute interstitial nephritis, and this was in the setting of infectious diseases in children, particularly diphtheria and scarlet fever. It's today a common cause of unexplained AKI. At least in one series, 27% of patients were presumed to have AKI from AIN. Drug-related AKI is one of the most important causes of AKI, and there are a number of drugs that have been implicated, including NSAIDs, of course, penicillins, rifampin, TMP, SMX, ciprofloxacin, proton pump inhibitors, which have recently gotten a lot of attention, not only for their association with AIN, but also with CKD. So there's a long list of agents implicated for AIN, but not just drugs. There are also infectious causes of allergic interstitial nephritis or acute interstitial nephritis, so severe Legionella pneumonia, which is characterized by multi-system dysfunction, hemorrhage, conjunctival suffusion, for leptospirosis. Remember that this actually was a board question on my boards. A patient with conjunctival suffusion, hemorrhage, and multi-system dysfunction, leptospirosis. CMV is another cause of AIN, and some cases of severe streptococcal infections can cause AIN. There's also autoimmune disorders, of course. Lupus can have a AIN component. Sjogren's and the TINU syndrome can also be associated with AIN. So the timing of onset is variable. It's been reported that the onset of AKI is 3 to 5 days after a second exposure, several weeks following the first exposure to a drug. But I think we've all seen it much earlier. And particularly with rifampin can occur very, very early, 1 day after rifampin exposure. That classic triad of fever, rash, and eosinophilia is not sensitive because it doesn't happen in everybody. It's thought to be only 10% sensitivity. And I've at least shown you one case where it was nonspecific, someone who had the classic triad but didn't have AIN. You can see white cells, white cell casts in the urine, of course, and this gentleman had those. The proteinuria in AIN is typically subnephrotic. You can also see a Fanconi syndrome, type 2 RTA. There are I like to do gallium scans in some patients There's conflicting reports regarding the sensitivity and specificity, but the gold standard diagnosis is, of course, with kidney biopsy, which reveals interstitial edema, an infiltrate with T cells, tubulitis. So it's a pretty unambiguous diagnosis with biopsy. The treatment approach to AIN is also quite controversial. First thing is a careful review of the medication list, including over-the-counter medications, discontinuation of any drug that is suspected of being the causative agent. Steroids are the big question. There has never been an adequately powered study of steroids for the management of allergic or acute interstitial nephritis from drug exposure. And I'm doubtful that there ever will be, given how difficult it is to study. So we rely on retrospective reports for our evidence base. There are some reports that early steroid therapy will speed the recovery of AKI from AIN. But this, the numbers of patients included in these studies is shockingly small. The paper that suggests steroids can help prevent progressive CKD included only 61 patients, and it was a retrospective study. So there are two papers, one by Gonzalez and colleagues in Kidney International in 2008, and one by Clarkson and colleagues in NDT in 2004. One of them is pro-steroids and one of them is con, suggests that there's no use. What Gonzalez did, this was that small study where he made the argument that if you delay treatment, so this on the x-axis is the delay in giving steroids, that your final serum creatinine was higher. So from this data, he thought if you do steroid treatment early, you have a better prognosis. Now this is very, this is not high quality evidence. It's not a randomized controlled trial. There's a lot of confounding here. There are many other reasons for the delay in therapy that could have been associated with the elevated creatinine at the follow-up. So Clarkson and colleagues also compared steroid treatment to conservative management with just discontinuation of drugs. And he found actually no difference in the serum creatinine at the final creatinine in steroid-treated versus conservatively managed patients. So here you have it. This is the evidence base to date. It consists of less than 200 patients. And one study suggests that you should use steroids early. The other study suggests that steroids don't have a role. So I think what I do and what many of my colleagues do is first discontinue the medication. If there's continued progression of the AKI that is not responsive to discontinuing the medication, then a trial of steroids is warranted. This gentleman got a mega dose of 1 gram of Solumedrol, which I think most of us wouldn't give, but 60 of prednisone a day for 4 weeks has been suggested by some, and then continuing it thereafter. So the data on steroids is extremely limited, unlikely to be an adequately powered trial in the future. So we're going to have to rely on these retrospective results unless someone's able to organize a pretty big study of steroids in AIN. Okay, last case. 47-year-old woman, previously healthy, on no medications, developed recurrent uveitis 6 months before she developed a rise in her creatinine. She had these episodes of uveitis were initially treated with topical steroids, and they improved. She was referred to me because her creatinine rose to 2.5 in November from a baseline of 0.9 in February. So she had mild hypertension, conjunctivitis bilaterally, a really unremarkable exam. No abnormalities on her cardiovascular exam, no rashes, no tenosynovitis or arthritis. And her labs were notable for a creatinine of 2.5, as you can see here. She had glucoseuria and subnephrotic proteinuria, and white cells on her urine sediment with no casts. So the biomarkers we obtained in this individual are listed here, and they were all pretty unremarkable. Negative ANCA, negative anti-GBM, normal complements, normal SPEP, UPEP, and negative ANA, normal ultrasound, and no abnormalities on her chest x-ray. So the most likely diagnosis here in this young woman with potentially interstitial nephritis and uveitis is actually the TINU syndrome. This was the presumptive diagnosis in this individual. So TINU syndrome, this is one of those diseases you may see on the boards, first described in 1975. In addition to eye and kidney, you can have systemic symptoms of fever, weight loss, fatigue, malaise, abdominal pain, arthralgias. The uveitis is usually bilateral, usually anterior chamber, and it can either precede or follow the episode of nephritis. Women are more commonly affected than men. Treatment is not well defined, but steroids have been used in severe cases, although many reports of spontaneous resolution have been reported. The pathogenesis here is unknown, but it may be that there's a common antigen in the uveal cells as well as the tubular cells. So this is what happened to this patient. Came in with a creatinine of 2.5. I suggested biopsy. She deferred. So I suggested prednisone 60 a day. She actually refused. But she actually improved spontaneously. So this is a case of tubulointerstitial nephritis and uveitis. So to summarize, we talked about 4 cases. We talked about rhabdomyolysis. We reviewed obstructive uropathy. We talked about AIN that was actually ATN. And finally, we had a case of TINU syndrome. And here are some references for your review, and thank you very much for your attention.